the various features. I'll be bringing on our speaker here shortly, but just a couple of things. Chat is like the business card exchange. Just the most important thing there is remember to use all panelists and attendees. That way everybody can hear your see your message. Second, we love to make these interactive presentations. And when do you get the undivided attention to ask a question of a physician? It's and you're not in there for an appointment. So it's a great opportunity to ask questions today. So we're gonna, you can ask questions two ways, by raising your hand or typing in the Q&A box, and we will do our best to get to all the questions. And then another little navigation tip is that sometimes folks are sort of like, well, why do I only see, this person's face or what have you? In the upper right-hand corner of your screen, you can play around with the gallery view and the speaker view, and that will hopefully make things easier. The other thing that I like to point out related to chat is sometimes people find that the chat can be distracting in these sessions. And so you can minimize that chat by just clicking on the chat button again, and it'll go away, and then you can refer to it later. And after this meeting, we send you a copy of everything in chat anyways. So once you get your contact info in there and you've said your highs to other people in the group, then that's great. And then lastly, I'll just, last slide I got on here is just to remind you, at proaging.com, you can order source books, you can check our job career center, you can view all the different online events that we've got, and you can also join our ProAging interactive community. But anyways, let me stop sharing my screen and let me welcome our presenter. I am super excited for us to welcome today Dr. Drew Falconer. And I tell you, it's always great when we get to talk to a physician, especially in the middle of this COVID-19 crisis, but to sort of share to hear your thoughts and to answer our attendees' questions. So first off, now how many people call you Dr. Drew, or does that kind of annoy you when you get called Dr. Drew?
No, Dr. Drew's fine.
Okay.
Most are Dr. Falconer, but Dr. Drew is a majority. It is, that's fine with me. I was old enough to remember the Dr. Drew Pinsky who would answer your questions late at night. So
yeah, Loveline, so
exactly.
And you never know with our audience, you might get a few of those questions, but tell us a little bit about your background. And I know that you're currently leading, a very innovative medical practice with Inova.
We try to, or at least we pretend to. Yes, so my name is Drew Falconer. I am a neurologist by training. So I did a residency at Georgetown in DC in neurology. And then I stayed on for extra training to get specialty designation as a specialist in Parkinson's disease and movement disorder. So my life 5 days a week is leading the Parkinson's and Movement Disorder Center here at Inova Health in Northern Virginia. It's a wonderful place to practice, and it's a wonderful place to do what I do, because Inova is really positioned as a very large health center in Northern Virginia. Everybody thinks about them as big Inova, and there's a reason for that. It really does control and give service to about 70% of the health market here in Northern Virginia. But about when I joined in, I think it was 2015, Inova was going through a transition. They were deciding that they didn't just want to be a community health system that was good at all the basic care, but if you needed something special, you had to go into DC to one of the academic institutions. They really made the decision that they wanted to create an academic style centers for different things out here in the community. And so they tasked me and Dr. Rogers, who's one of the other specialists we have, with building an academic level movement disorder center out here in the community, with the idea that, okay, one of the biggest hurdles to updated modern medical therapies for Parkinson's disease, one of the big hurdles between doing well with Parkinson's compared to doing just okay was access to specialty care. So if we created an academic center in the community-based setting, all of a sudden that accessibility problem falls by the wayside, and that's what we've managed to do. I'm very proud of the fact that we tend to be one of the most accessible physicians you'll ever find. In fact, if you message me through my chart in our patient of mine, you will probably hear back directly from me within 2 hours. And so it was that idea that we wanted to really make subspecialty driven Parkinson's care accessible to everybody. And we've really done a bang up job on it. We are 5 years in. We just hired our 4th movement disorder specialist. So come August, we will have 4 doctors that all we do 5 days a week is movement disorder care, which is mainly Parkinson's disease, but also gait issues, tremor of any kind, dystonia, muscle tightness, anything that is under that category of things that make you move different. And we are, I think, per our count last year, we take care of about 1,650 patients with just Parkinson's disease. Between our 3 docs, we hit almost 6,500 clinic visits last year. So we are busy, but in a way 5 days a week that is fully focused on patient care and fully focused on being accessible to patients. Because there really is, for anybody on this call who is the member of a care living facility, healthcare, assisted living, anything like that who takes care of Parkinson's disease, you can really palpably see the difference between a person who's treated with a kind of algorithm from 20 years ago versus treated with the modern way. The difference is astounding in a way. So that's our role here, is to be out in the community, to be accessible, and to update patients their meds. And a big part of what we do is community outreach. So we give educational talks all the time. Since COVID began, we very quickly changed to trying to deliver education through webinar means like this. We started a once weekly, essentially averaged out to once a week webinar series on anything patients wanted to talk about. We did talks on modern therapies, on the technology we use like deep brain stimulation and Duopa. We've done multiple just question answer sessions where patients will log in and we'll just have a conversation for an hour or so. What else? Sonia's on. She knows this list better than I do. We've done all kinds of stuff. We had our neuropsychologist do a talk. We're doing a talk about non-medical treatments like exercise and diet. It's really just trying to keep us engaged with the community of Northern Virginia and whoever wants to join, with the idea that education is so key in this. Because Parkinson's disease is not a complex disorder. It is really just a chemical deficiency in the brain. The tank is low. Your brain needs more dopamine, and it's low. And so our job is to fill the tank back up. And part of patients doing well is educating them on what their disease is, but also how their medicines work, the limitations of what they're taking, and what this newer stuff offers to try to improve that dosing curve, if you will. And patients love it. They get it. It's a very simplistic equation. And at the end of the day, it's really exciting because patients then become a partner in that discussion about what to do. And you're not having that, oh, doc, you just tell me what to do and we'll get better. No, they'll come to you and say, I saw your webinar. I think I'm wearing off and my medicines are failing me because of blank. And my answer is, take the white coat. You got it. So what do we do about it? Here's some options. Then we move forward as a team. So it's exciting.
Yeah, no, thank you. No, this is great. Now, you touched on a couple of things there. So, but, and I definitely want our audience to be raising their hands or typing questions into Q&A for Dr. Falconer. But you touched on something. There's 2 things that I'm hoping you can expand a little bit more for me. Sure. Is most of the people that are on our call are providers that work with older adults. So sure. Some things that we can look for as we are out there serving our elders. But then you also touched on sort of the old way of caring for movement disorders versus the new way. Could you dive into that a little bit more, or into those 2 topics a little bit more?
Absolutely. So 2 very different things. So let's start with what the community of support personnel, if you will, who interact with these patients on a daily basis, what they can do better. Is that fair? Mm-hmm. Okay. And I mean that in the most positive ways, because we are all this community built around these patients. And what I like to tell these patients is, remember, My role is to be here as kind of the captain of the ship to help guide things. But patients interact with so many different people on a daily basis that I consider very, very important, but very different touch points. And it's everything from home care who comes to help them with their bath once a week, physical therapy, occupational therapy, speech therapy, case manager if they're involved. If they live in an assisted living, it could even be the desk person who tells them hi when they're walking to go eat their dinner, though right now everybody's in still sort of lockdown. The point is we all interact with these patients frequently, much more frequently than us medical professionals. So the opinion and the eye of the community of everyone else is incredibly important. And it's important for a couple reasons. One, it's really important that if any of these different touch points see something being off, that they let us know. And we have a great working relationship with the therapy groups in our area, with most of our assisted livings, and they know that if they call, or especially if they call Sonia, they're going to get somebody right away. So if something is off, if the person is more lethargic, if they're a little confused, if it's their therapy day and they can't move like they used to, if they're in bed and it's hard getting them out, anything that's a derivation out of the normal, let us know, because that keeps me from having to follow up with the patient 2 or 3 weeks or months later. Then the family members say, oh, they've been doing terribly for months, but we were waiting until our next appointment. So my request is anybody in the community of support around these patients, the network that's built around these patients, if you see anything off, let us know. And the second big thing is, especially for any of that network around a patient who interacts with their medications, especially assisted livings, even on a nursing home level, or even just basic a community care center where medicine is managed, the timing of these medicines is incredibly important. I know, and we run into it all the time, about how state law gives about a 2-hour window around a time for medication administration. And trust me, I empathize with the complexity of caring for however many people in a certain, in an environment. But these Parkinson's medicines, especially when someone is more advanced in their disease, the timing is incredibly important. And it's the difference between maintaining consistency of benefit or introducing into the system a very inconsistent and fluctuating response. And that's a pretty good segue over to the old versus the new, how we treat Parkinson's disease. And to do that, actually, do I have the ability?
Yeah, you can share.
I was going to try to, I don't know if I've been,
Sure.
Can you enable it?
Yep, I got it.
Here's what I'm going to do.
No.
I got it.
You can share.
Oh, good. And I have a whiteboard too. Awesome. I want to show it to you because I think this will make sense on a number of different levels. And it'll also kind of bring across the point as to why the timing of medicine is so incredibly important. Because in the aside is, I actually have a form letter that I just put the patient's name in on when I want to send a very, very polite request to an assisted living or even a total care facility when I'm asking them to be more accurate with their timing. So here's the deal. Remember, Parkinson's disease as a condition, and anybody who works in this industry knows that it's actually a relatively common condition. It is a condition that is not based on a structural problem. The brain is fine. It's intact. The receptors are intact. The pathways are intact. With Parkinson's disease, if I do an MRI of your brain, a structural picture of the brain, it should be fine. There's nothing wrong. Parkinson's is a problem of a chemical being low, and that chemical is dopamine. These patients are a car driving around and their tank of gas is empty, and the gas we have to give them to fill up their tank is dopamine. It's very much akin to your type 1 diabetics who need insulin to function. If they don't get their insulin and it's not in the right dose or the right time, the wheels fall off. Except in Parkinson's, it's not insulin, it's dopamine. And so for these patients, and I hope everybody can see a blue smiley face?
Yep.
Okay, good. For all these patients, if it is a chemical problem, if they are a car that's driving around 24 hours a day with their tank being empty and the gas is dopamine, then there's a certain level of dopamine that I have to get into their system 24 hours a day to fill the tank up. And if there's a certain level that it needs to be achieved to fill the tank, then there's a certain level that's too much. And I'm going to keep them between these two lines. It's something we call the therapeutic window. Because if they ever dip below this level, they get the symptoms of Parkinson's. They start to tremor, they start to become slow, they become tight, they become quiet, they start to get anxious, they start to want to just be left alone and be withdrawn because their body's just not right. And the symptoms of too much are actually the opposite of that. So when people think of Parkinson, some people think about Michael J. Fox and when he would get all dyskinetic and move too much. Well, too much is a term called dyskinesia. And it's actually a symptom of being too high. Because if you think about it, Parkinson's is a condition where everything slows down. Well, dyskinesia is actually kind of the polar opposite of that. So our goal is to fill their tank up to get them above the line where symptoms come out, but not too high where they get dyskinesia and symptoms of too much. Because remember, dyskinesia, that Michael J. Fox movement, is not actually a symptom of Parkinson's disease. It's a side effect of the medication. So the old way of treating was we have this medicine, carbidopa-levodopa, that's been around since 1968. It's a chalky little yellow tablet. According to Michael J. Fox Foundation data, 80% of people are maintained only on this because the honest answer is the majority of doctors, or majority of Parkinson's patients, are cared for by general neurologists who, this is the medicine that's always been the gold standard. It works well enough. It's what people are comfortable with. But the problem with classic Sinemet, or classic carbidopa-levodopa, is that it does give dopamine back. Levodopa turns into dopamine in the brain and fixes the dopamine deficiency. But when a patient takes a tablet of that old Sinemet, it shoots up like a rocket and drops like a stone in their system on a window of about 4 hours. And the problem is, as Parkinson's advances, this window starts to narrow. And it becomes a harder target to miss. So what happens later on in the disease, and I'll make it green, I'll make it blue just to keep consistency, is that you get a window that's a lot smaller. And so when these patients take their Sinemet, they go up and they hit a period where they're a little over the mark and they get side effects. And then in about 3 to 4 hours, they crash and they go down. And then they take another dose and they go up, then they go down, and they go up, then they go down. And their day is very pulsatile, it's very inconsistent, and they get maybe 2 hours or 3 hours of good for every hour or so of being off. And so the classic way to treat this was, okay, we've got a chemical that fixes dopamine. Well, why don't we just move it closer together if it's not lasting as long? And patients end up taking this stuff every 2 to 3 hours all day, all the time. And all they do is they end up having a whole lot of dyskinesia and symptoms of too much for some degree of benefit, but yet they're still taking pills every 3 to 4 hours. And look, take it as a human being, not as a healthcare practitioner. If you were to tell me you have to take medicine every 2 to 3 hours to feel marginally better, I mean, good luck, right? It's terrible. So this is how it was classically treated, and for a lot of people, it still is. Now, over the last 20 years, we have developed 16 new therapies and medicines that are designed to fix this. And in fact, in the last 2 years alone, we've had 10 new medicines come to market that all are designed to fix the dopamine problem in a smooth, predictable, and consistent way. For all the people out there that know diabetes, it's very much akin to, this was like, the old way was like telling a patient, let's try to get by with bolus insulin during the day, where you literally have to do a shot of insulin every 2 to 3 hours. Those patients would do terribly. And all of the new therapies are designed to try to create a basal level of dopamine or a basal level of insulin where it's smooth, predictable, and consistent. And they get better. I tell our medical students, it's the first visit for a lot of these patients is actually not that hard. I just try to take them out of a treatment regimen from the 80s and 90s into 2020, and magically they do better. Now, this is no knock against their doctors. I love their general neurologists. I know them incredibly well, and they're doing what they know, what they're doing, their best, they care. But remember, a general neurologist takes care of every neurology condition out there: headache, MS, spinal disorder, neuropathy, back pain, Parkinson's, everything. They're jack of all trades. Because a specialist like me just does this 5 days a week, I know this toolbox, and I know how to use these medicines correctly. So that's the difference between old and new. And it also really illustrates why timing is so important. If 80% of patients are taking a medicine that only gives them about 4 hours of benefit, then if you add a 2-hour window of medicine when they can get it, you could be giving them the medicine way too early and causing their peak to be extra high, causing dyskinesia, hallucinations on down, or you might be missing this trough completely and unnecessarily giving them a really long period of feeling miserable. So the timing of these medicines, even the newer ones, can be the difference between a patient doing well and not. And the second big thing I'd like to share with whoever interacts with these patients, and it's never a fun thing to talk about, though if you hang out with my family at Thanksgiving, they always end up talking about their bowels. You have to talk to these patients about their bowels, because all of these pills have to go through their system to work. And I can't tell you the number of wonderful emails I get from physical therapists or home care nurses who will literally say, "Hi, how are you? This is great. I'm so embarrassed to have to say this, but Mr. So-and-so has not had a bowel movement in a week and he's doing terribly." When these patients get constipated, all of this goes out the window because these pills have to go into their gut and have to be absorbed by their gut to move. So just heading off constipation earlier can also be the difference between doing well and falling apart.
Wow. Well, I bet you've seen some real life-changing situations from people. Like, in fact, in the chat, where was it? I just read it. Is Brett just said, "My father was on these medicines. He had to take it every hour. My mother used a timer to remember. Not easy." This was the 1990s.
Mm-hmm.
So, boy, thank you. And now I know why Sonia Gao praises you. You are just very excellent at explaining a very complex topic and making it easy to understand. And I think this also really speaks to the value of a specialist, you know, I mean, for movement disorders, but for many conditions, you know, migrating to a specialist, you can really focus on specifically on what her condition is. Well, I'm glad that we got a ton of questions that are coming in. And so what I would say, we'll start reading through these, but folks, if you've got questions, now is the time to throw them into Q&A, or you can raise your hand if your preference would be to talk to us verbally. But let's start with Sharon Lucas, who says, "Sometimes patients are diagnosed with Parkinson's disease, and then it is learned later that the patient has Lewy bodies. Do you also work with Lewy body dementia?"
Yes, 100%. And you need a specialist who does movement disorders on board, because here's the trick. Okay, by the way, I'm a big whiteboard person. I hope that's okay.
Jump back. I love that.
I'm the person, if I had a dry erase smart marker, I might sniff it a little bit. Just kidding. So here's the deal. Parkinson's disease, PD, has Lewy bodies. Lewy, okay? In fact, I'm trying to do this with a mouse, so I apologize. The pathognomonic protein that we see when we slice someone's brain and look at these cells that have Parkinson's, that are the affected cells, are Lewy bodies. So Parkinson's disease is a Lewy body condition. Lewy body dementia, the dementia you're describing, is a dementia that goes along with Parkinson's disease. You have to have Parkinson's to have Lewy body dementia. And we get people all the time who come to clinic and they say, "Oh, the doc said I have Lewy body dementia, but I don't have Parkinson's." That's nonsense. You have to have one to have the other. And it's a spectrum. So here, I'm going to put early. Here we go. Good mouse skills, right? And late. Okay. If you are diagnosed with Parkinson's with dementia early, you are called Lewy body dementia. If you are diagnosed with Parkinson's and you develop dementia later, it's called Parkinson's disease dementia. There is no difference between these two. They're the exact same. The only difference is the time that it happens. It actually happens due to an important physiologic reason. At the base of the brain, I'm gonna get out of red. Red's a little bit of an aggressive color. There's a structure called the substantia nigra that Parkinson's comes from. It's the factory that produces dopamine. And when it gets filled with Lewy bodies, dopamine is less. Okay, let's not overthink it. There's a structure right next to it called the nucleus basalis of Maynard, for all the science nerds out there, that works on memory. So this is movement, this is memory. And when the Lewy bodies start to get into that nucleus, you get memory issues and dementia. My point to that is it's all part of the same disease. So if you have Lewy body dementia, you need to have a movement specialist, because it's really important to treat the cognitive issues and the movement issues. And they tend to be on opposite ends of the seesaw, where if you overdo one, the other gets worse. So you really have to balance the two. It's a hard trick for general neurologists to do. So you really need a doc like me to be on board for that.
Wow. Well, that I'm sure is an eye opener for a lot of the providers on the call, is the connection between Lewy body and Parkinson's. Just out of curiosity, like, how is your practice is a movement disorder practice specialty? Is that pretty unique nationwide? Are there are there other practices similar to yours?
There are. It's becoming more of a thing in the community. Classically, it's been a kind of specialty you had to go to an academic institution to to be a part of. Like in our area, the big centers before we came along were Georgetown was the big one. GW has a smaller group. They love them to death. And then the Baltimore, University of Maryland, and Hopkins. And there was a smaller group in Northern Virginia of 2 docs that have been doing movement for a while, but we were the first big center to actually be out in the community. So it's becoming an easier thing. Which is good.
Yeah. Let's see. David Sloop says he has 2 questions. When is it best to introduce DBS? Is it reliable go-to therapy? I'm amazed by it. And 2, when tremors begin to escalate again, how is dosage adjusted?
Great questions. So when is it best to introduce DBS? Well, to answer that properly, let me tell you what the FDA says. So the FDA is the strictest law in the land. They're the ones who tell us the indications, which then also translates to insurance covering it, right? So according to the FDA, and this is our rule too, you are a candidate for DBS if you've had symptoms or diagnosis for only 4 years. 4 years, it's early. And you have to have Parkinson's disease, and you have to feel the fluctuations of your medicine. Those are the big ones. And that's when we start talking about DBS. So DBS is a amazing, life-changing technology. It was one of those moments in the history of science where we created something that very honestly probably came off of an alien ship they have hidden somewhere. Like it's amazing what it does, because it's not an overly complex subject. We have a pathway in the brain that Parkinson's runs in, and we also know the pathway that essential tremor, or the kind of opposite tremor that I know we'll talk about here in a minute, runs through. And it's an electrical pathway. And when you take your medicine for Parkinson's, the medicine goes through that pathway and calms down the overexcitability of it, if that makes sense. Well, DBS is like a pacemaker, except instead of going into the heart to run the rhythm of the heart, the wires go up and go into the brain to run the rhythm of the brain. And they go to that pathway that we know and let us essentially block the electrical overexcitability with electricity, with energy. And it's adjustable, it's programmable, and it's real-time response. We turn it on and program it, and a patient will be tremoring, and it just stops. And the patient has control. They can adjust it. They can program it too if they're having a good day or a bad. And the real benefit to it is it does what the medicine does. You get the same response to DBS as your medicine at its best, except it's on 24 hours a day. And so once you have DBS, all of a sudden we lean on that device for therapy, and we start backing off on people's medicines, because the medicines then become an accessory, and the DBS is really making them better. And that goes to the outcomes. It's incredibly reliable. If you look at outcomes, there was a study 2 or 3 years ago where they asked patients after DBS, did they experience a meaningful improvement to their quality of life? And 95% of people said yes. So in my world, 95% just kind of counts as everybody. It works. And it works too, because then we can drop people's medicine by like 60 or 70%. So like that drawing from earlier, if pulsatility and inconsistent response is the problem, DBS just takes away the pulsatility and inconsistency. It is a beautiful therapy. And we need to use it earlier. And that's the thing. The average time from diagnosis to DBS is 12 to 14 years. But the FDA, strictest law in the land, says 4 years. There's a gap there that we can only bridge through education to try to get people to consider this life-changing therapy earlier.
Wow. Okay. And then I had to do, because I'm acronym
Yeah.
averse, but deep brain stimulation.
Yes.
Just
Deep brain stimulation.
folks out there that are not familiar with the acronym. Okay. So let's see. As a result of COVID-19, has there been any significant impact on the symptoms of Parkinson's patients since they are unable to engage in outside movement programs consistently and with other PWP?
Great question. And I was just checking to make sure my door was locked. It's the great joy of working from home. It sounds like the 2-year-old is killing an elephant right now. So she's not coming in. So we're good. This is wild. Great question. So the answer is yes. We have seen a significant impact on our population, and it's due to a number of things. The positive is, and it's just me being honest, because I tend to practice medicine in a very different way than a lot. I'm a very personable person. I know all of my patients. They all know me. They know my kids. They know my story. Our visits are like, I always run late because we just sit around talking about life for a period of time. But I have actually not, I can count the patients of mine who passed of COVID on less than one hand, probably 2 or 3 people, which is wonderful because our population is here in a hotbed and they're all over the age of 65 with comorbid medical issues. But the problems I'm seeing, and this is something that I think the folks that are on this call can help remedy, is that a lot of these patients are just sitting at home decompensating. Because yes, I can stabilize their medicine. I can make their brain get the smoothest, most predictable dopamine they can. But that's only one piece of the equation, which is why I swear to you, if I could herald someone as the key to a patient's longevity, it's the rehab folks, PT, speech. You have to rehabilitate these patients. They have to move. They have to exercise. They have to work with a physical therapist, an occupational therapist. They have to work with a speech therapist. They got to get out there and do things. And so I'm just seeing these sweet 80-year-old patients sitting at home, being locked into their assisted living because they're on quarantine. And now things are opening up. And I'm just telling them all, you got to get out to rehab. You got to start doing exercise stuff online. And I'm trying to coach them that they have to take advantage of the virtual options out there. Because if they just sit at home and do nothing, they're just going to get worse, and that's what's happening. And I'll use that as a quick moment to tell folks what they can do. Please help get in front of these patients or educate them on the need to move, the need to exercise, and the fact that they can do it at home. They'll tell me they're walking slower and they're more weak and they can't stand up as well. What's going on? And my answer is the obvious one: you're not moving. I tell them all once, twice a day exercise. What else are they doing? That's what I tell them because they're in quarantine. And if they start exercising, they will get better. But the second thing is, and this is what folks on this call can help with, most doctors, including our center, we're all virtual visits. So it has never been easier to access specialty care than right now. In fact, right now, if you were to call or message Sonia for a new visit appointment with our center, you would see a specialist probably in 2 weeks. Our schedule has been so positively altered because of these virtual visits. I'm not driving an hour into the office. I don't need an hour for lunch. I'm fitting people in left and right. And we've seen just an exponentially huge increase of new patients over the last 3 months because they just have to log into their computer. So the 2 things I'd ask people to do is, 1, make sure these patients are educated that they have to keep moving and that they can, and that there's remote PT, but when it's available, they got to do it. And 2, they got to keep seeing their docs because they can. And if they need a specialist, now is actually a really good time to try because it's easy right now. It's not the 6-month wait of a year ago.
So, before we hit some more of these questions, I'm just kind of curious in hearing your reflection on you as a practicing physician pre-COVID and the way that you would manage your clients and schedule your meetings, and now during COVID, as you were alluding to with the telemedicine visits, if you had to wave a magic wand and let's say that the world returned to normal in a month,
Sure.
Would you advocate to continue with the telemedicine for a portion of your practice?
Oh yeah. If we could do 50-50, it would be a measurable benefit for patient access and outcomes. Well, think about it this way. And we've seen this. I think Sonia ran the numbers. Between three of us, we saw almost 300 new patients in about a month and a half. That's insane. We never could do that because we never had the availability, and people, it's just that's a lot of people. The reason why is because it's so easy.
Yeah.
And the honest truth is, a virtual visit, if you Zoom call me like this, 9 out of 10 times, I can tell you exactly what to do to get better by doing root stuff through the video. Oh, my speaker just dropped out. Can you hear me still?
Yep.
Okay. I can still do things, but at the same time, you don't have to drive in. And then and so it's created this ability to access us that takes the barrier of travel out, which is such a barrier for patients who are homebound, who are in assisted living, who have to take a whole day to come and see us. And at the same time, too, our visits are much more efficient. There's something, the honest truth is, there's something about when you come in person. Oh, and Sonia said in parking their car. Yeah, you don't have to park your car to come and see us either. But there's something it's fine, but it's a lot more inefficient to see a doctor in person. You come in, you've driven in, I want to talk to you about life. You feel like, and it's the honest truth, that you don't want to come in for a 10-minute appointment and leave because you took an hour to drive in, right? So those visits are a lot longer because there's a lot more social interaction and social appropriateness. You log into a Zoom call, we might be able to get done in 10 minutes, tell you what to do. And because it's so easy, I might see you next week to see how you're doing.
That's great. Yeah, we're discovering all these positive elements out of this very negative life experience. Jennifer Brown says, does the patient's weight affect dosage, timing, etc.? No,
the weight's fine. It's really their GI health. If they're really constipated, it becomes really a hard target to hit. For most patients, it's all about just getting it on time.
Okay. Stephanie Moore says, can you speak briefly about essential tremor? How common is it and potentially debilitating? People sometimes assume I have Parkinson's disease at 50 and I take 60 milligrams of propanol LA. I inherited it and showed symptoms as a child, and my 78-year-old father struggles as well. Any new treatments out there? What is the latest MRA focused ultrasound instead of DBS?
You got it.
Still considered unsafe, speech issues, etc.
You got it. Great question. So essential tremor is the polar opposite of Parkinson's. The old term for essential tremor was benign familial tremors, because just like that lovely person wrote, it tends to run in families. It's usually inherited. And they called it benign because it's just tremor. But they changed the name because if you have bad essential tremor, it's not very benign. And it doesn't have to run in families. People can just spontaneously get it. So the new term is essential tremor, which really stands for a tremor that affects the essential activities of life. So essential tremor is a tremor that comes out with activity. It's a person who, when they're writing, it starts to shake. They go to drink a cup and it shakes. Utensils shake. But at rest, there's no tremor generally. It is a far more common condition than Parkinson's disease. It's maybe 10 times more common than Parkinson's, if not more. The issue is, and this is no knock to anybody with essential tremor, but it's a community that's really hard to get to. And we've been debating as specialists for years, why is that? And it comes down to a number of things. Because at the end of the day, my practice, which is movement disorders, which, by the way, I can make essential tremor stop. It's something that you should not have to live with. And as a specialist, I have tools that make it go away. But 80% of my patients are Parkinson's, and about 5% of my patients are essential tremor.
Wow.
Even though it's 10 times as many people. And the reason why is because people with essential tremor, not saying this person does, but in general, the idea is it's genetic, it runs in my family, my dad had to deal with it, so in a way, I kind of have to deal with it. And there are a lot of patients who had poor experience with medicine, and that translates through with this idea that there's nothing you can do about it. And if you look at the numbers, I think it's 90% of essential tremor patients are only treated by primary care or family practice, not even a neurologist. So it's a hard group to get to. It is an incredibly treatable condition, though. There are the downside is like the question alluded to. There's really been no development in terms of new medical therapies over the last 20 years. So there are really just 3 medicines that work to treat essential tremor. And they all work differently. And what most people miss is that if you take them together, they work better than if you take them apart. The three medicines are propranolol, which the question mentioned, though 60 milligrams is pretty much a starting dose. It goes all the way up to about 400 milligrams. And most people with essential tremor need about 120 to 160 milligrams to show a response. There's primidone, which is an older medicine, and a medicine called topiramate or Topamax. If those three don't work, which sometimes it doesn't, DBS is darn near curative for essential tremor. The expectation for response for essential tremor with DBS is that most people see complete resolution of their tremor, gone forever, because as it changes, you can adjust the device to make it stay gone. Or if it's not gone, it gets at least 80 to 90% better. That's darn near curative in my book.
Wow.
Now, there was this new technology that came out called focused ultrasound, which was FDA approved right now for essential tremor. They're trying to get it approved for Parkinson's too. It's something that we're still debating the role of. And the reason why is because it's not a benign therapy. So people think ultrasound and they think, oh, we do that to take a look at babies. That means it's safe. Well, in reality, what focused ultrasound is it's remember earlier I was saying that there's a pathway that tremor runs through, and if we put DBS in it, we can block it. Well, all focused ultrasound is doing is concentrating like 1,000 ultrasound beams onto that pathway, and when they all coalesce, they create heat, and so it's creating a lesion, a physical block of that pathway. So it's actually injuring the brain tissue and creating a structural problem to block the tremor. And like the question alluded to, it's good if you can have DBS, but it should never replace DBS. For one, you're taking an electrical problem and making it a structural one. And then after a few years, your brain is smart and works around it. And what are you going to do? Keep burning holes? And two, you can only do it on one side of the body. You can never do it on both because there's such a high risk of injuring the wrong thing, creating speech issues or paralysis. If you do it on both sides, you could die. If you do it on one side and they miss, well, you just can't speak or move that one side. So I can tell you in the past 5 or 6 years, I've sent people for focused ultrasound, not once.
Okay. Well, Stephanie, I think you need to talk to Sonia and go in and talk to the practice. It sounds like we could have some positive results there for you.
We could.
Let's see. John Conroe says, how does the CD get from the gut to the brain, and is the fatty substances and iron affect absorption, and does the vagus nerve have a part of the equation? You can read the question there. I was trying
Mr. Conroe is one of my favorite patients. I just have to put that out there. He has filled my my ledger of jokes for Parkinson's disease that I feel like I have to put a book out and make him the author. He's a great guy, and great questions too. So carbidopa-levodopa gets from the gut to the brain by being absorbed through the gut, going through the bloodstream, through the liver, and pushes its way into the brain. In fact, when a patient takes one of those tablets of Cinemet, only about 5% of that dose actually makes it to where it needs to go. If you eat a fatty meal, fatty foods actually delay stomach emptying, for anybody to know. So if you eat a big fatty meal, that's why you feel crummy for so long, is because fatty foods make food sit in your stomach longer. So if you take a pill that has to go out of the stomach with a fatty meal, it doesn't kick in for a lot longer because it's just sitting in your stomach. And then I'm beating the constipation horse today. It just screws the whole thing up. The final iron is okay. You shouldn't take iron salts. It can make you even more constipated. In the vagus nerve, there's a theory, and it's a pretty good one, that Parkinson's actually starts out as a gut problem. That you first start to get Lewy bodies in the gut, and then they travel up this nerve called the vagus nerve to the base of the brain where they create Parkinson's disease. And there's evidence of that. And it really goes to the idea that by the time you're diagnosed, by the time you see me and I say, unfortunately, this is Parkinson's, most people have been experiencing constipation for 10 or 15 years before their diagnosis.
Ooh, wow. Kate McCarthy says, husband with dementia of Alzheimer's type, probable FTD, high dyskinesia, what test would rule out Parkinson's? And maybe you can elaborate on that question.
There you go. I'm going to make it easy.
All right.
So
we like the whiteboard.
There are 2 brain scans that would help you out. An FDG PET of the brain or something called a DAT scan. Look those 2 up. So an FDG PET of the brain is a type of PET scan that takes a picture of how the brain is burning energy. In fact, the FDG stands for glucose, which is sugar, the main fuel of the brain. If you have Alzheimer's disease, the brain stops using energy as well in specific areas that are very different than the specific areas of frontotemporal dementia, which is FTD, which are very different than the areas of Lewy body dementia or Parkinson's. So by getting an FDG PET scan of the brain, which should be covered by most insurance providers, the pattern of the picture should tell you the difference between Alzheimer's, frontotemporal dementia, and Parkinson's dementia. The second thing is, we have a wonderful brain scan that's been around since 2010 that is FDA approved to tell us if you have Parkinson's disease. That is the DAT scan. So DAT stands for dopamine active transporters. So if Parkinson's is a chemical problem, if the brain is low in dopamine, then you will have an abnormal DAT scan because it will show that your levels of dopamine are low. If you have Alzheimer's, frontotemporal, anything else that isn't Parkinson's, it will be normal. So I think we have to answer that question, you need to do one of these two tests. Now, what I'll tell you is it's not fair, just between you and I, to sit on a diagnosis of it could be one of the 3 types of dementia. You got to know which one because it's all a different prognosis, it's all a different course. And if it's Parkinson's, it's treatable. We can treat the movement side as well as the cognitive issues.
Wow, great. Let's see. The Jennifer Brown says, have you seen patients with vascular dementia and Parkinson's?
Yes. So this goes down to the question of chemical versus structural problem. Here we go. Going back to the whiteboard. I live my life on whiteboards.
You should just leave it up.
I'm just going to leave it up. That's fine.
Yeah.
So remember, Parkinson's is where dopamine is low, right? Low dopa, which is a chemical problem, right? The tank is low, the car is driving around empty. That dopamine is supposed to go somewhere in the brain to work, right? It goes and it flips the switch. There's your switch. It's like a light switch, right? Sort of, maybe, fair. Okay. If your symptoms, which is the switch, are coming from the dopamine being low, you have Parkinson's. If you have a stroke in the brain that injures the pathway, the symptoms look the same. Does that make sense? So that's the difference between Parkinson's disease and what's called vascular Parkinsonism, where it's a vascular reason. It's strokes that have injured the road that dopamine travels on and not a chemical problem. At the end of the day, whether the road is broke and dopamine can't get where it wants to go, or the dopamine production is low, the symptoms can be very similar. And it's very important to differentiate the two because it's a very fundamental thing. If you're producing all the dopamine you can, but it can't get to its target because it's being blocked by a stroke, then the medicines don't work. Because if I give you more dopamine, it's not going to do anything. If your symptoms are coming from your dopamine level being low, Parkinson's disease, the medicines will work. So vascular Parkinsonism, if that's what it is, really needs to be viewed as a post-stroke illness, not Parkinson's disease. Because at the end of the day, we can try a little bit of medicine, but rehabilitation, intense physical therapy is the best thing to do, as well as making sure all the safeguards are in place so that you don't have another stroke.
Yeah, great explanation. Heidi Garvis says, have you used
Noradans? Yes.
Noradans, and have you had success when added to the medication regime?
Yes. Noradans is a good medicine, and it just came out 4 to 6 months ago. So again, in the past 2 years, we've had 10 medicines, new medicines that come out for Parkinson's, and they are not like the 15th statin that its whole job is just to lower cholesterol. No, they each do something unique and different. So Noradans is the newest to the group. It's called isradiphyline, and it goes down to how do we make people move better. So in the base of the brain, there's the pathway that Parkinson's runs through, and it's been the scourge of medical students because there's 2 different ways to go through the pathway. There's the indirect and there's direct, okay? So in Parkinson's disease, the direct pathway is low, and that's the dopamine. And so every medicine of the past 100 years has been trying to fill the direct pathway back up with dopamine. We've never been able to affect this indirect pathway because in Parkinson's, the direct pathway turns down, the indirect pathway actually becomes overexcited. So we consider this indirect pathway like the brake on the gas, that if you have Parkinson's, you're both dealing with having a low gas tank, but you're also dealing with somebody driving with their foot on the brake. Well, Norians is the first medicine that blocks this. And so it is a completely different way to free up movement in Parkinson's disease. And it does it completely differently from all the other medicines. The other cool part is it has a half-life when it lasts in your system of 82 hours. So if you're talking smooth, predictable therapy, having a medicine that lasts 3 days is kind of the definition of it. I put a lot of people on it. You're either going to respond to it and feel better, or there's a minority that it just doesn't do what you expect. And so I take about 20% of people off, but the majority feel some benefit.
Wow. Gretchen Gaines says, what can you say about a client who has a 50-year history of schizophrenia and more recent, maybe 25-year diagnosis of Parkinson's, now considered by some to be tardive dyskinesia, and refuses to get a scan?
They need the scan. They need a DAT scan yesterday because here's the deal. Does that look like a seesaw to everybody?
Yep.
So schizophrenia, no, SCHIZ, and Parkinson's are on complete opposite sides of the seesaw. Okay? Schizophrenia is due to a hypersensitivity to dopamine. Same dopamine, same hormone. Parkinson's is due to not having enough. So they balance out by being complete opposites. Okay?
Wow.
Now here's the deal. All of the treatments that treat schizophrenia, the vast majority treat it by blocking dopamine. Okay? Because it's too much. When you block dopamine consistently over time, patients can look like they have Parkinson's disease. For no other reason than by consistently blocking their dopamine, their brain starts to turn the receptors off and they get Parkinsonian type symptoms that are not truly Parkinson's disease. They are what we call neuroleptic induced Parkinson's. They're created due to the antipsychotic medicines. And over time, if you keep blocking those dopamine receptors, they get something called tardive dyskinesia, where they get that dyskinesia and the wiggling movement, but usually it's in the face. They get like mouth and tongue movements. They get oral automatisms. Yeah, I think it's the right word. It's all because of chronic exposure to antipsychotic medications. Completely different than Parkinson's disease. And the reason why is I deleted my seesaw. But remember, schizophrenia is, I don't know why I want to skip the C. Schizophrenia and Parkinson's. The problem is, if you try to treat someone for Parkinson's with schizophrenia, with dopamine, you're going to make their schizophrenia go nuts. And for a lot of people, if they're on a medicine to block dopamine, you don't want to then give them medicine that stimulates dopamine, right? So differentiating, is a dopamine deficiency at play, is Parkinson's at play, is absolutely critical. And for these patients, that's where the DAT scan comes in. Because it will tell you where the dopamine level is.
Now, what is involved in getting a DAT scan? Like, why would somebody refuse to have one?
It's a relatively simple scan. There are some medicines that you have to be off of for a day or two that could influence the DAT scan, but most of the antipsychotics are okay. The reason why it's a PET scan. So what you do is you go into the it's Woodburn Nuclear Medicine that does it for us. They put an IV in and put some dye in the blood that binds to the dopamine receptors. The patient then just has to hang out for like 3 or 4 hours to let it stick. We have patients that before COVID would drive over to the mall and just walk around the mall for 3 hours. They come back and it's like a CAT scan of the brain that takes about 20 minutes. So it's a pretty easy scan. And then we get the results within a day or two. So I don't know. Maybe they just don't know about it. I don't know.
Yeah. Well, fingers crossed we can get that scan for that patient, because I think that's a perfect storm there with those two conditions.
Yep.
And
Agreed.
We are to our last typed in question. The timing couldn't be more perfect, but I'm throwing that out there in case somebody else has
Sure.
question that they would like, and you can raise your hand or type it in. Brian Miller says, since the GI environment is so crucial to medication effectiveness as well as the overall health, what recommendations or protocols do you prescribe to clean up the microbiome for Parkinson's patients?
It's a great question. So the best thing for that would be adding some degree of natural probiotic to your life. So in the pills work, the active, whatever it is, cultures that you take, they work, but there have been a number of studies that taking probiotics in some sort of a non-pill form actually works better. So your yogurts, I love yogurt. I tell patients, eat some yogurt, but remember, if you overdo dairy, you can get more constipated, so be careful. Some people love that kombucha tea stuff. I think it tastes like socks, so I can't do it.
I can't eat that. I can't drink that either.
Yeah, in fact, funny story, my mom used to do her own kombucha tea because that was, I guess, her and her sister's thing. She had some and gave some to my son, who's now 5, when we were last at the house. Not some she made, she just bought it at the store, but she loves kombucha tea. He drank it, and she said, oh, don't drink too much or it'll give you diarrhea. So now, every time we talk about kombucha tea, he calls it the diarrhea tea. So just to give you but that's a 5-year-old. My point is, if you like kombucha tea, it's a great source of natural probiotics. Kefir or kefir, the liquid yogurt's great. There's many different ways to get active culture. It helps a lot. Sonia also offered, and I love her to do it, we have a great recipe of a natural mix for GI health and constipation. Works great. And she'll put it, if she's still on, she might pop it up into the chat box. It's relatively simple. And again, I'm from the South, so everything is a cup recipe. You know, like a pie is a cup of flour, sugar, and you name it. Cobbler is just that plus butter. There she put it up. Great.
Oh boy, that's quick.
So what you need to do is get a jar of some kind, one that you can put in the fridge, and you put a cup of bran cereal, a cup of applesauce, which I hear if you use apple cinnamon, it tastes even better, and a cup of prune juice. You mix it together. You put it in the fridge. It tastes a lot better when it's cold, and it tastes kind of like a cold oatmeal. Then every morning you just eat 2 or 3 scoops of that, 2 or 3 spoonfuls, and it gets the gut moving. It keeps constipation at bay. And then she also put, remember to drink a lot of water, and exercise helps too.
Great. Man, this is amazing. Brian Miller says, just curious if you promote the anti-inflammatory diet protocol.
No, not at all. And it was important because you said promote it. Do I think it's good for you? Sure. I think that just between you and I, all of the diet fads of the last 20 years are all a lifestyle choice, not a medical choice. Remember that. None of them will help your Parkinson's or life directly to the disease. They will just help you live better. So you will see that people will do better on a Mediterranean diet. But what is a Mediterranean diet? Lots of fish, nuts, and veggies, right? Surprise. People will do worse if they live on cheeseburger diets. Surprise. It goes back to the idea, and this is what I tell patients, don't get too lost in the world of dieting and supplements. You just need to do what your mother always told you to do. You have to eat well, eat a well-balanced diet, lots of fruits, vegetables. Fish is fantastic for everything. Lay off the fatty processed food and exercise. You got to treat your body. That's what they used to say, treat your body like a temple, right? Only put the good things in it, and you got to exercise. It's all about movement and keeping your body healthy, because then everything else falls in line.
Great. Man, well, I am indebted to Sonia for getting on your schedule and booking you. This is probably one of the most fascinating sessions that we've done, and I really appreciate you taking the time to meet with us this Friday afternoon.
Absolutely. If you don't mind, could I share with the group our website and Sonia's contact info if they need anything?
Absolutely, and I'm sure Sonia is going to be typing away furiously. Everyone's doing it. But
already have. She's coming.
What we're going to do is we're going to email that out to everybody along with the recording. And Sonia, you can email me, any kind of materials. But again, thank you so much, Doctor, and keep on doing your great work. And
one day at a time.
All right.
Well, and remember, everybody, one last thing. We're all in this together, and this is a very scary and different time, as I again hear my children trying to kill each other in the other room. But we're going to get through this. We're a community together, and we are part of these patients' lives every day, and we all have a very important role to play, and it's really important that we work together. So if there's anything we can do or help with, please do not hesitate to reach out. It is all of our doctors. We have hired people who their life mission is to make people's lives better with Parkinson's. So if there's anything we can do, there's Sonia's number. Call her and you'll hear directly from us. We are here for you, I promise.
Great. Thanks so much, Doctor. We'll see everybody next week at our next sessions. Okay, bye-bye.